And Good Morning Kenya gets to continue. Today being a Tuesday, it is Health Tuesday, so we get on to a different topic on matters health, and this particular one is very, very needed. It is a conversation that is not really spoken about that much, but it is a condition that is there. It affects so many women in this country, and it's just about time for us to get to talk about it. We are talking about endometriosis, and in studio with me today, I am more than pleased because we'll be getting two perspectives on this condition. We have a gynecologist who is here, and then we'll also be having an endo warrior. So with me on my far left, we have Dr. Laureen Mengesa. She is from the Kenya Obstetrical Gynecological Society. Welcome to the show.
Thank you.
And then we also have Elsie Wandera. Elsie is an endo warrior. Welcome to the show.
Thank you so much.
It's a pleasure to have you ladies on set with me today for us to talk about this condition that is endometriosis. And just maybe to begin, just a quick search on Google on the data on endometriosis in this country, and research shows that there is no really appropriate data on it. So I'm like, okay, probably yes, we should talk about this.
Yeah.
How come maybe, Doc, how come there's no definite, data on endometriosis in Kenya?
So for a very long time, the question has been, is there endometriosis in Africa? And a lot of people have actually thought that this is a disease for white people. And so a lot of effort has not been put into just figuring out, do we have this in Africa? Do we have this in Kenya? Are black women suffering from this? Because about 70% of the cases that have been reported have been from the West.
Yeah.
But now with time, we are actually starting to realize that we do have endo in Africa, and a lot of it are that.
Yeah.
And so we're now just starting to get more research into it, and with that is how the data is coming up.
Okay.
So previously there wasn't too much information because it wasn't thought to be an African problem. Yeah.
All right, I understand that now. Kindly explain to us what endometriosis is all about. Someone was trying to explain to me, as I was telling you earlier, and they said if they were to explain it in the easiest of way that one would understand, they would say, you see the way we have, this skin, our mouth, so they were explaining it's like the way this side is as it should be, and then on this other side, the inside is now on the outside. The lining on the inside of your mouth is now bare, it's outside. Kindly just explain to us, that's just in very layman language, so just explain to us what endo is.
So endometriosis means that we have normally the lining of the uterus. So this is on the inside of your uterus, what is normally preparing essentially to receive a pregnancy every month, and what is shed when you have your period every month. So it is when you have this lining occurring in places outside the uterus. So this can either be on the walls of the uterus or completely outside. So it can go onto your ovaries, it can go on the ligaments that support your uterus, and in extreme cases, it's completely ectopic, meaning you can find it in your chest. You can find it in your eyes, you can find it in your ears, you can find it on your belly button. So the problem with this is that this kind of lining, it's supposed to respond to hormones. So every month, cyclically, there's hormones that are playing around in your body. This is what is giving you your menstrual cycle. So these same tissues, wherever they're found, they're responding to these hormones. So meaning if you had this tissue, for example, in your chest, every month it's being stimulated by those hormones and it's bleeding. So it's bleeding and creating, foreign products in your blood, in your body where they're not supposed to be. And this is now generating some inflammation, some irritation in your body. And that is where the pain comes from. So you have the lining that was supposed to be in your uterus now occurring in sites where it's not supposed to be. And that is where the problem begins. Yeah.
All right, I understand that, and I'm more than pleased to have, Elsie here with us because we can get to hear her side of the story. So Elsie, let's get to listen to your story. When exactly did you start having issues, for you to get to a point where now you've been diagnosed and it is endometriosis, and how long did it take before you got to know that, okay, it's endo?
Thank you for having me, and I'm just really excited to share my lived experience. So, like you said, my name is Elsie Wandera, and I am, of course, an endo warrior.
Yeah.
And that's why I'm dressed in yellow, because yellow is actually the
that's
color
the colour
of endometriosis.
Oh,
So
we
in this
missed the
month,
memo.
yes, we missed the brief, you guys. But you know, so here we are representing the voices of the millions of the women who are out there who continue to suffer in silence. So for me, I started presenting my symptoms when I was about 13. I think when I started my menses quite early. But I remember that was the first time when I, experienced pain, and I was like, what is this? Is this normal? And I remember when I was asking around, the narrative was, that this is normal and this is expected, that girls should actually suffer and women should actually suffer in silence. And silence there is the key word. So it took 13 years for me to actually be definitively diagnosed, because again, the norms in society, where narratives like, painful period is normal, where, for example, there was shame associated with me visiting a gynecologist, right, to talk about these issues. And, so we're not, at that time, and even today, I don't think we are pushing people or we're encouraging women and girls to actually seek to protect actually their reproductive health in general, right? So for me, when I first walked into that doctor's office, and then I was talking about this issue, I think I was about 26, and I remember I walked in there with my then boyfriend, and I was talking about my symptoms and what I was going through, and he just said, you have endometriosis. I was like, what? Like you? It just sounded like such a mouthful, and the way he was explaining it sounded just so. I was like, what is this? It sounds like such a foreign disease. Like I must have this disease that no one has ever suffered from, and no one has ever, no one knows about. So the easiest way he could describe it to me, so similar to what you were being told, is that my uterus was growing inside out. That was the easiest way for me to actually understand what I was going through. So it took me 4 years, it took me 13 years, and I'm 44 this year, actually turning 45, and I've had 4 surgeries to try and treat and manage the condition. Lost my ovaries. I was actually telling Daktari just, due to the progression of the disease. And now I'm on HRT. So that's really the disease. But I know there are more questions that we can unpack, just because that feels like a lot, right?
It definitely does feel like a lot. It is a lot, actually. Now, maybe to you, Doc, as she said, we've normalized period pain. That is just the usual. Like, as a woman, you just know when it's that time of the month, you expect to get your, it has a name, forgotten it, but you get those cramps. That's the name. You expect to have the cramps, and it's just the usual. So when should it be alarming? Because now, as she said, she went and she was, it's normal, it's kawaida, you've started your periods, it's normal for you to cramp. So when should it be alarming, and what are some other symptoms of endometriosis?
Okay, so period pain is not normal, contrary to what a lot of people are led to believe, and probably that is what led to her waiting 13 whole years for her to make a diagnosis. Because what happens is there are 2 things that are highly normalized: heavy bleeding and pain. And you kind of adapt to it, and as you're saying, you anticipate it, knowing that my period is coming, let me go and get my Buscopan Plus and everything, let me just be ready for this because I know what's coming. So mild cramping can happen, and that can be normal. A bit of discomfort. Some people have a lot of awareness during their period, just the discomforts that come with it. But once you have pain that you must have a painkiller for, once you have pain that is making you unable to do your normal day-to-day things, you can't go to school. So if you have a child in high school who period means sick pay, so if they're on their period, then they have to be at the nursing station. That's a problem. If you can't go to work because of your period, you can't do your gym, you can't do your sports because of your period, that is not supposed to be like that. So that is abnormal. Other things that sometimes come, so sometimes this pain for some people starts like on the first day of the period, but there are people who start getting pain even days before. It's like, a premonition. They're just already starting to see that pain building up. Other things would be
There's
pain,
actually a
even
picture on our screen. Yeah.
yes, for the endometriosis, just to show what we were describing of the lining, which is what is in red, and how it is now existing in other places outside the uterus, and which is what is causing the pain. So period pain in that level definitely is not normal and needs you to actually see a doctor.
What are the
Other
symptoms?
things that can also show up is you can have pain even when you're doing other things, like when you're passing urine, you have pain. When you're passing stool, you can have pain. I see Elsie nodding, maybe she knows exactly what it is, and it's excruciating. So normal things that your body should do without that level of discomfort, and they're giving you that much pain, then that's a problem. For patients who are already sexually active, then pain during sex is a problem. That is definitely not supposed to be there. Other things sometimes, because if you see from the picture, so there was the endometriosis that goes outside the uterus, but there's also endometriosis in the wall. So this tissue is also not supposed to be on the wall, just on the lining. So if you see those little dots on the wall of the uterus, when you have endo there, then it makes your uterus not function well in terms of contracting during your period and stopping that heavy bleeding. So excessive bleeding during your period, heavy bleeding, that is a sign that you could be having endo. So sometimes it may not necessarily be just the pain, these other things can associate. And something very important to note is that sometimes the pain does not necessarily indicate how bad it is. So sometimes you have small lesions, but they're causing extreme pain. Sometimes you have larger portions of the endometriosis and the pain is moderate. So you cannot necessarily say, you have just a little pain, so the endo is not that bad. It really, really varies extremely widely.
All right. There's something she also mentioned, the late diagnosis. She had to wait a whole 13 years before she got diagnosed. And this is a story for most endo warriors. Even the late Jambi Koikai, God rest her soul in peace, she was talking about this and speaking about the fact that, hers was also very late. It was diagnosed when it was a bit too late, So maybe what's the reason? Is it that we don't have enough equipments in the country? Is it that we don't have enough qualified, gynecologists or, to be able to point this out early? Because I believe it goes in stages, and the earlier it is diagnosed, maybe the better. So just why?
So the why question comes from different directions. So one of them is just awareness. As I said earlier, for a long time, this was not thought to be an African problem. And so what we call index of suspicion, which means when you come to me as a doctor, the moment you start talking to me, there are things that are coming to my mind as to what could be going on with you. And so when this is not top of your mind as a possibility, then you end up treating every other small thing. So you're like, okay, take these pain medications, let me see you in a month. And typical patients, they'll probably come back next year because they've been taking those painkillers you prescribed, they'll take them again for the next 6 months, 12 months. Then when the pain graduates to another more severe level, then they come back. Another thing is sometimes, typically when you see an gynecologist, you'll be asked to do a scan. But not all scans can pick up endometriosis, because sometimes these lesions are so small. They're like very tiny, tiny dots, and so the ultrasound might not pick that up. So by the time you're picking it up and seeing it clearly on an ultrasound, probably you've progressed to larger issues and more prominent kinds of things. So I think awareness has been one of the biggest things that has been affecting, how fast this is being diagnosed. Awareness both on the patients to actually know, this is a problem and I need to actually come and see a doctor, and awareness on the practitioner to be like, okay, this is not normal and I probably need to dig deeper into this. And then in terms of making the diagnosis itself, sometimes it's not so obvious, not so direct. Some imaging might miss it. So you also have to really listen to the patient and to be able to understand the pattern of this pain, to be able to say, what, I think this is endo. Yeah.
All right. Before we get to, there's another diagram you had sent. You wanted to talk on. But before we get to that, maybe we can get to listen to Elsie. Just how different was your experience during menstruation compared to every other lady out here who is not suffering from endometriosis, and just get to describe that for us, so that as we said from the beginning, this is a condition that most people don't know about, and it's about time for us to create awareness on it. So if you can just describe how that was for you.
Yeah.
If you're open to describe the pain as well, let us in on it.
Absolutely. I think it's that it's important and to talk about it, because again, you know, at that young age, pain was normalized, right? So what endometriosis was, so for me, throughout my cycle, so whether I was on my period, whether I was ovulating, whether I was just relaxing, between those, you know, the 4 stages that we know of our menstrual cycle, I was in pain. I was in constant pain. And so I was very heavily medicated. So like Dr. Mengesa is actually saying, a lot of us are reliant on pain medication and over-the-counter pain medication. Yeah. So for me, the normal, like, you know, like the normal painkillers that I would get over-the-counter would not work for me. So it meant at least once or twice a month, I was in hospital. I was in casualty or the ER, getting pain medication intravenously. To describe the pain, how do I do this?
Yeah.
It feels like a cactus inside, or it feels like a grenade that's actually exploding, that's going off. And so the posture for me was, I was always in a fetal or bending position. You know, so there was always, and my family would know, and I really bless God for them because of the support that they gave me through that time. You know, my mom would know, like, it's time for a hot water bottle, or, you know, she's in bed, or she's going to be screaming and shouting and just crying out for help, and, you know, to be rushed to hospital. And so that's what used to happen. And what that meant for me, even when you think about my career, like, you know, that disrupted, you know, a few of my days in terms of just being able to work consistently throughout the month. So I think on average about 2 days of work were missed out. And I think, you know, that's what my life looked like. Sex was painful, just for your information. So I completely agree and can relate with what Dr. is saying. So for me, that was it. And also painful bowel movement. Like, I dreaded eating. So I feel like I had some PTSD towards just because I'm expecting my periods. It was nasty. And you know, just like eating for me during that time was problematic because I feared going to the toilet, because I was just like, who's going to experience all of that pain? And I wasn't looking forward to it at all. And I think for me, just that constant reliance on medication, and I keep saying right now, because I'm not on my periods, I'm like, I don't miss my periods, which is such a strange thing for a woman to actually say, because we're supposed to love this thing that God has given us, right? It's not supposed to be so torturous. It's not supposed to torment us for the rest of our lives. But that, for me, my life was never pain-free. I don't know how people, if you guys, both of you, had, you know, painless periods. I don't know what that, I don't know, I can't relate to that. I just can only relate with pain.
Okay.
And so I feel like that's the thing that distinguishes me from
everyone.
Yeah.
It's really unfortunate. Now there's the other diagram, Dr. Mengesa, if we can have it on the screen, that you can also get to describe what the diagram is all about. But even as we get it, maybe, does endometriosis affect a specific demographic of women? Does it affect any a specific demographic of women, and what are some of the causes? But before we get into that, there's the diagram. Yeah. What's happening there?
While we get to that, I think I'll start with your first question.
Okay.
So Elsie has highlighted something extremely important. She started having the symptoms when she was 13, probably when you got your first period. And so endo can start from your first period.
Okay.
It can be your introduction to reproductive health, and that can be your story from then on. Commonly, what the literature says is between your 30s and 40s, that's when it peaks, in terms of that's when most of the cases are picked up. But you can literally have it from your first period, and you can have, what she's saying, a very, very like painful memory from the very first period you have, and you've never known anything else. Periods is pain, and that has been the story from the beginning. So from the first period, you can get endo and start presenting with symptoms. For some people, then it starts later. Now, the cause of endometriosis is still one of those things that I would say is unclear. We have theories. We theorize, what are the possible things that might be causing this endometriosis. And so one of the things that we have definitely figured out is there is a genetic component to it. Meaning if you do have relatives, like for Elsie, if she has sisters, close relatives who have similar symptoms, then there is a high likelihood. So if you have family members with endometriosis, then your risk becomes higher. There's theories that say, people who start their periods very early, or they have very short cycles, 20, 22 days, very heavy flow, then there is a theory about the menses retrograding, meaning going backwards. And so what the theory imagines is that the bleeding comes up and out through the tubes and then goes and sticks in different places, and that's what creates the endometriosis. So we don't have, a particular thing which we will say this is the cause, but those are some of the things that have been brought up as risk factors. So what you're looking at essentially was me just trying to explain, because you talked about diagnosis, and we did say that diagnosis is quite tricky sometimes to really pinpoint. Sometimes, you just know because you get a patient with pain and you give them medication and you see they're responding, and you kind of tell this is probably endo because she's responding to this particular medication. So what's up is just to show you what we call laparoscopy. And this is one of the gold standards of actually making a diagnosis of endometriosis. And so we're normally trying to visualize into your body and see with cameras. So what you're looking at is small devices. So we make small incisions on your abdomen and we go in with tiny cameras. And when you do that, then you're able to literally see how these lesions look. And we call them matchstick spots. If you can picture a matchstick and the black head on the matchstick, they look like dark spots like that. So you're able to see those tiny dark spots. You can also see what we call chocolate cysts. So she says she had her ovaries removed, so there is a possibility she had those. So what happens is you get these huge cysts in your ovaries. And because remember I told you this is tissue that was supposed to be having your period in your lining. So it's doing the same bleeding, and so it's accumulating old blood essentially. And this ends up looking like if you were to melt chocolate and pour it. So when we open them, that's what we see. So this allows us first to be able to make a diagnosis. So with laparoscopy, you can be able to look inside and see this is actually endo and establish the extent. Remember we said that endo is actually staged. So we have what you are calling very early disease, so stage 1, and this can go on until stage 4. So stage 4 is extremes, like people like the late Jambi Koikai, who you just mentioned, were people who are on the extreme end of the spectrum. There's also milder forms of the disease. So when we do laparoscopy, then we're able to first visualize the disease and confirm the diagnosis. We're able to tell the extent of this. We're able to also see, is there other things going on? Because what happens with endo, you can also have adhesions forming. Adhesions means because there's all this inflammation going on, there's some stickiness, some strands that form, and this also adds to the pain. So not only just the endo is causing the pain, but the reaction that's going on the inside is causing the pain. At the same time, you're able to also attend to the condition. That is, try as much as possible and resect. And by resect, I mean cut out and remove the lesions that you can see in as much as possible. And in some extreme conditions, we actually even have to have a general surgeon in the surgery, because sometimes it's gone even to your bowel. By the time you're having problems even passing stool, it means somewhere along, your GIT, there is those spots and lesions there. And sometimes you actually have to cut out portions of, your rectum if it's gone on there. Yes, just to relieve you of those symptoms. So this is something that's extremely important because, number one, it's minimally invasive. So that means that your recovery from the surgery is better, but it also gives us all these benefits. I can actually see her in my office after the surgery and we can look at the images and I can tell her, guess what, this is where the problem was, and you can look through it. And even when it comes to teaching, we can also use the same videos to be able to, to train and teach other doctors what to look for and how this condition actually presents. So at least we've gotten to a point where you can be able to diagnose this. Like there are ways to do is the laparoscopy and, other ways. At least we have that. At least we do. Now, Elsie, you mentioned that you've had to undergo 4 surgeries, and you eventually lost your uterus.
Ovaries.
Your ovaries,
ovaries.
not uterus.
Yes.
Oh, sorry about that.
No.
So kindly take me through that. You know, like, what point does it get to for the doctor to now decide, okay, now we have to do a surgery, we have to get rid of this, just from your point of view?
Correct.
And what was explained to you?
I think, and I appreciate the doctors that have walked this journey with me, because again, four surgeries on any one human being, just trying to treat the same issue is not easy. And again, like, I think my first surgery was to definitively diagnose, because by the time I was sitting across from the doctor, yes, he could hear the what I was telling him, he could hear what the symptoms that I was experiencing, but he needed to definitively diagnose and know the full extent, like, where is this disease and where is it like really manifesting and where is it causing a lot of the discomfort. And I remember some of the things that I think coming out of that first surgery, he told me, like, there was something like he did, like, called adhesion lysis,
yes,
which is, I think, chopping up those adhesions. And then he also, you know, just emptied like a sack of like the ovarian cyst that had actually come up like around my ovaries. And I think what happens during laparoscopy and is that, I mean, and during those surgeries of just removing those the lesions, I think there's a potential. I mean, there was potential for my ovarian reserve to be eaten into, because where the ovarian cyst is, the cyst is actually growing on the ovary. So, unlike men, because our ovaries, that's like our what would you call it? It's like a bank. It's a safe.
It's your safe.
So every time you keep like taking from that resource or that storage unit, you're depleting the resource. And that's what happened to me over the 4 years, because most of the how the endometriosis for me was manifesting is through those chocolate cysts. So several times, I think maybe twice or thrice, I think they went in and that harvesting happened. So by the time I was about, it was 38. I had, you know, my gynecologist at the time. I was working with a fertility specialist, and, you know, she was telling me that, Elsie, I think, you know, your fertility has been impacted, right? So if you're thinking about conceiving, you know, your ovarian reserve is low, and therefore you know, I suspect it's low because I think at that time I'd already lost one ovary. So she told me, okay, let's test and you know, just check where you're at. And so at every turn, the doctors were gauging how painful, like, what was the quality of my life, basically. How painful was how painful was the pain that they needed to actually give me that relief. And therefore that informed them then resorting to, okay, we've tried this other pain management, we've tried hormone suppressant methods, because there are different methods of managing, you know, and treating this disease, but there's no definitive cure. So for me, those were the things that they tried. And so by the fourth surgery, I mean, of course, I was just like, yes, I just signed papers. There was nothing. I was going in again for relief, just to get relief. But then by the time, you know, I came out, you know, I remember the doctor just told me, unfortunately, we could not save the last ovary that was there. And it was fine. I mean, I don't mean fine like it's okay. So, and I don't mean to normalize this if anyone is listening out there and feel like you need to do this and you need to go and put pressure on your doctor to do it. No. If your ovaries are healthy and are functioning, there's no need to remove them. Even your uterus, there's no reason, because that's not necessarily the treatment and the cure, like equivalent to give you relief from endometriosis. But for me, it was just because we needed to
get that relief.
Correct.
Yeah.
And
I hear you.
Yeah.
I hear you completely on that. Now, Doc, maybe, you know, as we almost come to a conclusion, does it interfere with one's ability to conceive? Is it one of the reasons of infertility? And even as you answer that, also you can take us through the treatment options available.
Okay, so definitely it's going to impact your fertility. So remember, this is where the baby is supposed to be. So you have your uterus, you have your ovaries. Now, Elsie has mentioned that this is your safe, this is your bank. Actually, when you're born, you have all your eggs with you. Unlike men who keep producing sperm, you're given your charges to walk around with from your birth. And so what happens is from the time that you're in your reproductive years, you start losing these eggs. And by the time you're getting to 35, the rate of loss of these eggs becomes faster. And that's why, you know, we have all this talk of, you know, I tell my patients, so are we thinking babies? Are we thinking babies? Can we start now? Because by the time you go beyond 35, then your fertility starts to drop. Now, imagine this safe now has something else interfering with it. It's not now just its natural rate of loss, but there is something causing inflammation. Inflammation just means, you know, irritation, producing harmful chemicals. You've had her describing a cyst. So when you have a cyst on your ovary, that could actually interfere with how your ovary is supposed to work. This means you're likely not ovulating as you should. So that means your capacity for getting pregnant is already being impaired. This wall that was supposed to be containing your pregnancy is undergoing inflammation. There's this constant state of inflammation, meaning if you're to get pregnant and the pregnancy comes into the uterus, it might not find it receptive to the pregnancy. And so you might be prone to having miscarriages, like preterm, you know, events coming in that allow you to lose pregnancies before they're viable. So definitely it affects your fertility. From other sources, like you can imagine if sex is extremely painful, this is not direct, but would you really be keen on even the process of getting this pregnancy there? So this also affects relationships because you're not keen on intimacy. Intimacy for you is not pleasurable. It's something that, you know, you're like, maybe let me just try this for today for the sake of him, but at some point it's too much, and even your partner will be like, every time I touch her, she's in pain. I don't want to cause her pain. So it's both your mind and your body and how you're experiencing your relationships, and also physically your body starts to have problems with this. Then remember, if you start having this way early, like now from when she was 13, so you're already having these symptoms from early on. You start having surgeries, you start having all these procedures. They're definitely going to long-term impact. So when it comes to management, we have medical options and surgical options, and this range from how severe is this. So sometimes something as simple as just your combined oral contraceptives, your usual, you know, chagolako, Yasmin type, can help, because what happens is when you give sustained hormones, then it tends to suppress the activity of this endo and prevents it from spreading. Then there are more developed medications, things like Visan. I'm sure this has come up a lot, for you. And so they're hormonal treatments, largely hormonal treatments, either oral or injectable ones that try to suppress endo from progressing and from developing. Alongside this, there's always the pain medication. And one of the things I always say to my patients is, please don't self-medicate, because sometimes what my patients do is, now you give them this one pill, tell them, can we see how this works? So when the one pill doesn't work, they take 4. So you just keep graduating up on the scale. Now you're getting heartburn, you're getting side effects from this pain medication, and it's not working. So pain medication always comes hand in hand with the hormonal treatment. Then next step is now surgery. Like we said, with the hysteroscopy, surgery is both to make a diagnosis and to treat the condition. And the surgery varies from just trying to excise the areas with a problem to completely removing the uterus, the ovaries, and any other areas where the condition might have affected.
All right, we need to finish up with this conversation. I feel we still need more time. But good thing is, March is Endometriosis Awareness Month, so we definitely need to create more time to have this conversation. In the fewest of words, I wanted to speak to someone who's just been newly diagnosed and they feel like, okay, my life is done now. Just very quickly, that's your camera. Just speak to her.
Okay. I want you to know, one, that you're not alone. There are very many women who are out there suffering, but I want to also assure you that there are many community support groups. One that I started, that I turned this pain into purpose, and started the Endometriosis Foundation of Kenya. And through that, we also created a program called the EndoBuddy program, where you can come in and join, and we can actually pair you up with someone who will be able to walk this journey with you, so you are not alone.
All right, you are not alone. I want to leave it at that. Thank you so much, ladies, for joining me for this conversation, and I hope that you will avail yourself if we get to call you back, because we can never get to an end of this conversation. So probably still sometime this month, we'll create time for that as well.
Thank you so much for having us.
Thank you. Thank you so much for tuning in, and I believe that you've gotten to know now about endometriosis for those who didn't know nothing about it. For those who knew about it, yes, the awareness is now out there, and we need to put it out there more. We need to be loud about it. For anyone who's suffering from it, it's not the end of the road. Now, I have been with my beautiful ladies here, the beautiful guests. We had Dr. Laureen Mengesa, and we also have Elsie Wandera, and this is where we come to a close of today's Good Morning Kenya. My name is Vivian Dagwa. Thank you so much for tuning in. Do enjoy the rest of your viewing. Goodbye.